Everyone, my name is Ambika Kapil, and I'm a third-year medical student at Nova Southeastern University. And today I'll be presenting on my project titled "A Late Occurrence of Thyroid Hormone Resistance After a Total Thyroidectomy for Papillary Thyroid Cancer." Now, this is a really interesting case because it emphasizes the diagnostic and therapeutic challenges in managing such rare occurrences. So here we had a 43-year-old female who presented with dizziness, vertigo, repeated falls, and a severe headache after a minor fall. Associated symptoms included nausea, vomiting, photophobia, cold intolerance, whole body aches, and fatigue. Her past medical history included a total thyroidectomy for papillary thyroid cancer, multiple sclerosis, pituitary macroadenoma, Cushing's disease, and polycystic ovarian syndrome or PCOS. After her thyroidectomy, she was on long-term levothyroxine therapy, but her TSH remained elevated, hence thyroid hormone resistance was suspected. On admission, her vital signs showed a blood pressure of 106/76, heart rate of 47 beats per minute, temperature of 97.2 degrees Fahrenheit, and an O2 sat of 99% on room air. On physical exam, she did have delayed deep tendon reflex relaxation. She showed a thyroidectomy scar and hirsutism, and her laboratory results showed an elevated TSH of above 100 and free T4 at the upper limit of normal, and free T3 slightly elevated, which is all consistent with thyroid hormone resistance. Her electrolytes and renal function were within normal limits, so hence her initial management included high dose intravenous levothyroxine. On admission day, we gave her 300, and we followed that by 700 on hospital day 1 and 800 on hospital day 2. Supportive therapy also included IV fluids, acetaminophen for pain control PRN, and nicotine replacement therapy. Further lab workup also included normal values for thyroglobulin that was below 1, a TPO of 13, an FSH of 4.1, an LH of 6.0, GH of zero point 0.2, as well as an 8 a.m. cortisol level of 5, and hence an ACTH stimulation test was performed, and the 30-minute and 60-minute cortisol were both within normal ranges. Hence, the patient's elevated TSH, despite normal slash high normal free T4 and T3 levels, strongly suggests that she may have thyroid hormone resistance. However, her clinical presentation, including dizziness, fatigue, and cold intolerance, combined with her history of the pituitary macroadenoma, required us to have a full consideration of alternative diagnoses. Here, it was really interesting though because we couldn't do a full genetic testing by the end, which was in our hopes in our workup, just because the patient did leave AMA on day 3. And so we concluded our study with the finding of a subclinical hypothyroidism paired with poor medication adherence and levothyroxine malabsorption. So this case overall highlights the complexities that were involved in diagnosing and managing a thyroid hormone resistant patient, especially in the history of a thyroidectomy and multiple comorbidities. Overall, the premature discontinuation of care further underscored the need for patient education and engagement in the treatment plan and emphasizes the importance of an interdisciplinary approach and careful monitoring in patients with these rare endocrine disorders to ensure a comprehensive and fuller understanding of their unique clinical needs. Thank you so much for your time, and please let us know if you have any questions. Have a great day.